Good afternoon, everyone, and welcome. I'm John McCarthy, a founding partner of Spire Healthcare Strategies, a healthcare consulting firm and key partner for the NORC MCO Learning Hub. The NORC NOC Learning Hub is committed to providing information and ways to address health equity and transform healthcare with a focus on MCOs, consumer groups, state Medicaid leaders, and other industry experts. The Hub will be hosting a new 6-part quarterly webinar series highlighting innovations in Medicaid. The webinar series will include national experts discussing the latest trends, initiatives, programs, and findings on timely topics important to improving the Medicaid program and meeting the needs of beneficiaries. The first in this series is centered on how Medicaid can meet the behavioral health needs of their members post-pandemic, which we'll dive into in just a minute. Before we get to the agenda today and the speakers for today, I want to note that all attendees will remain on listen-only mode. But please send us your questions using the chat box, and we'll get to as many as we can during the webinar. You can also find the slides for the presentation today on our Hub website. During the webinar today, we'll hear presentations from Dr. Mario San Bartolome, an addiction specialist and medical director for Molina's Social Determinants of Health Center for Innovation, as well as Mr. Jonathan Ciampi, the CEO of the SUD telemedicine program. The speakers will provide an overview of the national behavioral mental health need post-COVID, how Medicaid is covering SUD telehealth services, an innovative telemedicine program, successes, challenges, and next steps. After presentations from each speaker, we'll have a facilitated discussion and then use the last 10 to 15 minutes of our time today to turn to the audience questions for presenters. Our first presenter today is Dr. Mario San Bartolome. Dr. Mario is an addiction medicine specialist who is dual board certified in family medicine and addiction medicine. Dr. Mario serves Molina Healthcare members as the medical director for substance use disorders and co-leads the Social Determinants of Health Center for Innovation. Dr. Mario received his undergraduate degree from UC Davis, his MD from the UC Irvine School of Medicine, and received a master's in business administration from the Paul Mirage School of Business at UC Irvine. Dr. Mario has extensive leadership and healthcare delivery experience in all levels of care related to substance abuse and primary care. Then we'll hear from Mr. Jonathan Ciampi, who is the founder and CEO of Bright Heart Health, a telemedicine healthcare company focused on chronic disease management for behavioral health issues. Bright Heart Health is Joint Commission accredited and actively serving patients across 47 states. Bright Heart Health is a Medicaid, Medicare, and commercial insurance provider and engaged in various research projects, including SAMHSA, NIDA, NIH, and various state efforts. Mr. Ciampi is a member of the Joint Commission's Advisory Board and chair of the Alcohol and Other Drug Advisory Board and Contra Costa County. With that, I'd like to turn it over to Dr. Mario for your presentation.
Great, thank you, John. It's an honor for me to be addressing this topic. You know, as a family physician and addiction medicine specialist, this is really a passion for me. And over the last year and a half, we've had a lot of activity. So we'll be talking a little bit about the backdrop during COVID-19 as it relates to behavioral health, and we'll talk about some of the enhancements that Molina is engaged in to be able to address some of these, as well as talk a little bit about moving forward. What sort of things can we protect in some of those enhancements and maybe continue to move forward? So as far as some of the trends that we've seen, you know, before COVID-19, the pandemic, we were already struggling with the opioid epidemic and the rising impact of illicit synthetic opioids on overdose rates. COVID brought with it a combination of factors, right? The fear of the unknown, the stay-at-home orders, and a variety of opinions. This was all in the backdrop of a social unrest around race, around masks, and politics. To paraphrase from one of my colleagues, Dr. Nora Volkoff, who's the director of the National Institute on Drug Abuse, addiction and overdoses collided with the COVID-19 pandemic, and each one of them made the other worse. We see that. We see that now with the rates of social isolation, the impact on mental health, the impact on addiction, and of course, the data that we've recently been exposed to here after the counts were done around overdoses. So we know that in the case of social isolation, that was magnified, and the despair was really palpable. Social isolation interferes with support systems and access to traditional modes of treatment. You can no longer go to your 12-step meeting or any sort of a mutual support type of a meeting, and you can't access your friend anymore. So that caused a lot of upheaval. Social isolation also disproportionately affects those who are already in most need, those that have been basically hanging on by a string, as it were. And that, of course, fed into the increase in the need for mental health. There were increased reports of mental distress, particularly among individuals with no history of mental disorders and among younger adults, of racial ethnic minorities, of essential workers, and also of unpaid adult caregivers. So all aspects of the continuum really were affected. As insecurity around finances, around housing and food became more pronounced, so did the stressors on one's own mental health. And of course, those stressors equal triggers, and those triggers affect addiction. So several reports that already have revealed that we had massive increases in the number of positive urine drug screens, particularly around fentanyl, cocaine, heroin, and methamphetamine. And if you look at those, they actually parallel what was seen from the overdose front in terms of the rate of change in overdose deaths, and those synthetic opioids in particular, but also, surprisingly, around stimulants, psychostimulants. We also saw increases in cannabis and alcohol use, particularly among people with anxiety and depression, and of course, access to services were strained. Now, the emergency response to the pandemic did see some important flexibilities that did help improve access to some evidence-based care like medication-assisted treatment for opioid and alcohol use disorders, as an example. And of course, all of those things feed into what the resultant overdose rate, in the setting that we're in now. Now, when this hour is over that we're going to share together here, there'll be 11 people that will have died from overdoses, and we saw 93,000 people in 2020 die from overdose deaths, and that represented an increase of about 30%. And we can kind of look at what increased in the category around fentanyl, the synthetic opioid, and this is not prescription fentanyl, this is illicit fentanyl, but we saw a 55% increase. And from methamphetamine, we saw a 46% increase. And then from cocaine, we saw a 21% increase. So there are a lot of different things that we that the COVID-19 also magnified that were already coming along the way from the standpoint of synthetic opioids and psychostimulants. Now, from the standpoint of what we did, as an industry, we had to really rethink the way we provide mental health and substance use disorder care during this pandemic. For so long, we really put all the emphasis on seeing somebody in person, and that we somehow observed the patient a bit more thoroughly, and that was the premium. However, that wasn't possible during the pandemic. So with upward trends in mental illness and substance use, we really needed some quick solutions. So luckily at Molina, we had established telehealth partnerships with folks like the Bright Heart Health team, which you'll hear a little bit more about today. And we expanded that partnership to be able to access and engage people in medication-assisted treatment along with mental health services. Now, we also increased access to teletherapy and telepsychiatry through changes in our policies around PA edits. We also created a Care Connections pilot program to provide telehealth follow-up appointments. We also created a chatbot, a COVID chatbot for members to self-assess not only for COVID, but for mental health symptoms as a result of COVID stressors. And we also understand that caring for our members also requires best equipping our providers. We developed a BH COVID screening tool for primary care physicians to assess for the behavioral health impact of COVID, and provided education for both members and providers on the psychological impact of COVID. We've also launched our partnership with PsychHub in all our states. And of course, PsychHub is it's one of the premier online platforms for mental health education, and we want to arm our providers with the best and most recent information, as well as allow them to have continuing education credits for that. Now, for proponents of virtual care and telehealth, COVID was an amazing catalyst in the uptake and acceptance of these services. Both providers and patients that may not have considered using it before now are using it. But as the data has shown, it's especially true for behavioral health services. Now, at Molina, we saw telehealth utilization claims for all diagnoses increase from about 350,000 in the first quarter of 2020 to roughly 1.4 million in the first quarter of 2021. Now, the greatest utilization for that was from opioid use disorder, generalized anxiety disorder, major depressive disorder, and PTSD. The year-over-year comparison, we saw total telehealth claims utilization go from 770,000 in 2019 all the way to 4.2 million in 2020. So it was a huge increase. And behavioral health diagnoses accounted for 83% of the top 10 diagnoses in 2020. So that's a 45%, that's almost a doubling from what it was the year before. And in 2020, the top 3 diagnoses were opioid use disorder, generalized anxiety disorder, and major depressive disorder. So very significant. And it's important that we make sure that these services are meaningful to be effective. We know that as we see these spikes in utilization, we have to have the proper way to track these. We created an internal telehealth dashboard to assess ongoing metrics around telehealth utilization, and then to inform us on how to identify gaps, barriers, and opportunities, because this is all evolving. It continues to be evolving, actually. We also understand that telehealth accessibility remains unevenly distributed by income. Now, you heard in the beginning that one of the hats I wear is along the line of helping co-lead the Center for Innovation along social determinants of health. So this is a very important area. But we see the uneven distribution between income, geography, and other social determinants that are factors that we need to pay attention to and maximize our data systems to be able to figure out where to put our resources. Now that the floodgates have opened, though, we believe that more people will continue to use, even after the PHE. We just don't know to what level. Now, federal and state governments are rolling back some of the telehealth flexibilities now that we're getting towards some meaningful changes. It'll be important to continue to monitor these programs to make sure there aren't gaps in coverage for members, that we aren't removing services that were working for our members. In addition, we want to be able to leverage the data that we have and continue to identify what works for patients. And really, this is going to be a partnership really across managed care organizations, providers, members, and also care managers. So one of the things that I believe really contributed to the increase in utilization of telehealth was the use of audio-only telehealth. That wasn't available before the PHE. We're seeing, especially in areas with little or no broadband or homes with no internet or equipment, that this has been used and has been very useful. And in fact, many of our providers, for example, in the space around medication-assisted treatment, they've told us that they've seen higher rates of attendance for patients that are in treatment compared to in person. So what does that equal? That equals engagement. So you might have had a 60% show rate before. Remember that mental health and addiction carries lots of stigma still. People oftentimes won't show up or have other things that become social barriers, taking 3 buses to get to that clinic's office. But now they can show up, and no matter what, you're engaging. And so that increase in engagement is critical. What about moving forward then? The challenge here will be identifying what flexibilities and what enhancements during the PHE that will be necessary and clinically appropriate to continue after it's over. Over the next year and on, we'll be continuing to review our dashboards and outcomes and of metrics to continue to identify where these needs are at. And of course, there's going to be a heterogeneity from each state in terms of how they approach some of these. We believe that telehealth provides a proven mode of increasing engagement among populations that suffer from disorders most affected by stigma, as mentioned. We see the value in continuing the access of audio only as an option for those that cannot access broadband. we see that telehealth accessibility still remains unevenly distributed, as mentioned. So health disparities need to be focused on, and we need to continue to invest to fill those gaps. At Molina, we have a robust dashboards and information systems, and as mentioned, the Center for Innovation around Social Determinants of Health, and that is one of the main priorities, is to not only identify that, but to be able to close loops around community-based organizations and partnerships with providers. From the standpoint of medication-assisted treatment, which of course is one of the major things that we can do that's evidence-based to eliminate or to harm reduce, to decrease that overdose rate that we talked about in the beginning, is to continue to make that more flexible. Flexibilities around the Riot and Hate Act, for example, we support that, particularly around substances that are used in addiction treatment, like buprenorphine. Buprenorphine should not be treated the same as some of the other scheduled medications for lots of reasons. And I can tell you those reasons at the level of the chemistry, as well as the pharmacology, as well as from what we see out in the real world. There's also some other things in terms of how pharmacies are tracked, for example, that disincentivizes them to provide services like home deliveries, for example, when they're fearful of being tagged or flagged as an inappropriate provider of controlled substances, even if it's buprenorphine. And also eliminating limits on buprenorphine prescribing. If you can imagine, if I said to you, look, you've been trained as a physician to treat this thing called diabetes. You could prescribe insulin, but you can only prescribe 275 patients worth of insulin. Any more than that, I'm sorry, you can't do that. This is the silo that we've created and the reality that we've created for medication-assisted treatment. So we need to, and of course, there are things to think through on that, but it's one of the few areas that we do this, we limit. And it's already an area that we have very little, improvements in access and network adequacy because of a lot of other factors around X waivers and special DEA requirements. So, I think that some of those things should be really thought through and maintained. So I think I'll stop there, and I hope that we've given you a little bit of an overview of the plight of the trends that we've seen along COVID-19, both in the mental health space as well as in the area around substance use. We've discussed a little bit of some of the interventions that we've engaged in, and there are others that a lot of other plans and other organizations have done and that we can all learn from. And then also some of these recommendations that we think that in the Medicaid space that we can continue to hold on to protect and preserve the increase in access to care. With that said, I'll turn it back over to John.
Thank you very much, Dr. Mario. Really appreciate it. That's a really good overview there. I just want to have a reminder for anyone who is listening in on the webinar. If you have questions, please go ahead and type them into the chat box, and we will get to them after John gives his presentation. So with that, John, I'll turn it over to you at Bright Heart Health.
Great. Thanks, John. And, echoing Dr. Mario, I, too, find this to be a great honor. These are some of the biggest challenges we face in trying to deliver care and address some of the nation's biggest issues. Also, thank Molina for their forward thinking across the country on this. My goal here is to share with you what it's like to be on the ground delivering care. What are some of the things that we've attempted to do that have increased access, helped individuals stay in recovery, but also the areas where we're experiencing challenges that are related to regulations in states and other factors. So to do that, I wanted to give you a quick background on what it's like to be a telehealth provider, especially going through the pandemic, but also share with you some of the challenges that we're experiencing today in detail around stories that may help guide our post-pandemic efforts. So first thing is Bright Heart Health. We are a national telehealth provider. We do focus on substance use disorder, medication-assisted treatment, and other behavioral health conditions. We have a big focus on being or sharing our learnings with organizations. You can see the studies here, Joint Commission, as well as national studies. And we're doing this because we want people to learn how to deliver telehealth. We believe telehealth is very analogous to what you experienced with Barnes & Noble and Amazon. The idea that you're going to take a telehealth session and just replicate it as an in-person, so you're just changing the modality, is a simple way of delivering telehealth, but you lose out on the opportunity for better care. You lose out on the opportunity to understand more about the individual you're treating, understanding what are their challenges, as Dr. Mario said, transportation, therapeutic interfering behaviors, diversion, all of these things we can have better insights around in terms of our digital health engagement. Just like Amazon understands better what you're buying in terms of your books than Barnes & Noble did. And so I want you to think of telehealth as being an opportunity, not necessarily just a switch or a change in how patients connect to providers. For us, what we found in the pandemic and with the population we serve is that we had to be available 24/7. 24/7 meaning live video access real time, not a schedule within 24 hours, not anything that would sort of sign up on a form. The population we're serving, access is a key criteria to getting into care. When we turned on this virtual clinic, the idea that the patient could literally just click on their smartphone and be real-time video with one of our staff members and then in front of a provider, we saw over a double increase in access to treatment. So we were originally, or pre-pandemic without this, we were looking at about 2 to 3 out of 10 patients getting into care. And then during the pandemic, that increased significantly, and I'll go through the details on that. But that's rethinking the care model, right? We're thinking about how do we support emergency departments, police stations, drug courts, primary care, all the areas where patients are going to present and they need to get care now. How do we help them? Patient comes home or an individual comes home from, let's say, the bar late at night, fight with the spouse at 2 a.m., they finally decide this is the moment you're going to get care. They actually can reach somebody. And that's a big change in how we think about treating this population, removing the barriers, getting to where they are, not just stages of change and meeting them where they're at, but actually physically, in a virtual way, meeting them where they're at, geographically, time of day, all these things. So this was actually fortuitous that we had this virtual clinic come on because then the pandemic hit. And when the pandemic hit, just like Dr. Mario mentioned, we saw a huge increase in the number of admissions. And what's amazing is as we were operating across the nation, this was going up and up and up. And then if you were in a physical location and you relied on the staff within a physical geography, you would never be able to manage this type of growth. But in a telehealth world, this is, again, one of the areas where we see opportunity is the ability to leverage providers regardless of their geography so we can meet demand. And what was amazing is during this whole period, as you can see, our average time to appointment didn't increase that significantly. It started to in the beginning of the pandemic, but then it was quickly managed. So that was a big part. I mentioned we work across the nation just to kind of give you a sense because we have insight into what it's like to work under each state's Medicaid rules, licensing, regulations. We provide a number of services outside of SUD. And so I just want to bring that up as just context for where I come from in terms of our insights. And then also, we really take a comprehensive approach to treating these patients. They come in with all kinds of issues in addition to substance use disorder. It could be mental health, chronic physical health issues like diabetes. It could also be chronic pain. So we really want to take a comprehensive approach to that. And so we use a multidisciplinary team to deliver that care. But getting into the details. So as I mentioned, one of the key things that we saw was important to have this virtual clinic. This is our virtual clinic stats where you saw fax machines. When we would receive a fax referral, it's about 2 out of 10 patients would get into care. And I think that mirrors the SAMHSA information that we see. When we look at telephone, it moves up just a little bit, but it was really the virtual clinic. And why is that? Well, it's trust. As Dr. Mario mentioned, there's a lot of stigma, issues patients encounter in terms of how to get into care, reasons that they might choose to want to withdraw from care, whether that's social pressure, social determinants of health, transportation, income. With a virtual model, we are able to engage that individual, develop rapport, trust, and also start to understand what are the issues that the patient's facing and how do we get them connected to solutions, getting them connected to housing, getting them connected to case management at the health plan who might be able to provide them transportation, different things that the patient needs in terms of support services that can help keep them engaged in care. We can't do anything with a patient who doesn't show up to care. If they don't show up to care, we're not helping them. And so making sure that patients stay in care is really our first and foremost goal. then we can actually start looking at other outcomes. What I think is interesting about this is we start to think about the outcomes and what is telehealth showing us? Well, pre-pandemic, the outcomes all showed that they were on par with regular in-person care. What we're seeing is that the outcomes are much higher, and I think a lot of people got exposure to this, as Dr. Mario mentioned, in terms of no-show rates. Again, if you can't treat patients who don't show up, our no-show rate is somewhere in the neighborhood around 15 to 16%, whereas industry research shows it's somewhere up around 30 to 50%, and that has been studied multiple times. Our retention in care is over 90% at 30 days. Some studies show that it's usually about 50% in in-person care, and if you look at our 90-day retention, it's 75%, so significantly above what industry measures are showing. On the right-hand side, reduction in substance abuse. 97% of patients, this was just opioid use disorder patients, about 850. 97% of patients are negative for opioids at 90 days. If you compare that to the Lockwell 2017 study, I believe that number was around 40%. So again, we're seeing telehealth as being a highly effective way of treating patients. And there are a couple combinations to that. As I mentioned, a lot more insight on the patients, and I'll get into that on some of the barriers. But that's really a different discussion going into what are the components that make up telehealth and being effective at it. We also see other mental health issues reducing over time. Here's depression and anxiety. Dr. Mario mentioned that that's what a lot of patients were seeking through telehealth during the pandemic. A lot of patients with substance use disorder come in and have these issues, so you're seeing the reduction in the starting average PHQ-9 and GAD score. That's depression and anxiety. What's more important is really the time it takes to see those scores reduce. And that's important when we start thinking about care and looking at patients, what are we expecting at what time point? So it's not just whether or not we're achieving those objectives, but also when should we be achieving those? And so what are some of the limitations? And I think this is kind of the meat of the presentation, which is Dr. Mario brought up. When you think about a virtual clinic, one of the keys to making a virtual clinic work is the ability to move a patient in front of a provider, a medical provider, who can evaluate them and prescribe them medication. If you have a patient who's in withdrawal, we want to get them onto something like buprenorphine as quickly as possible. Obviously, we need to do a thorough medical assessment. We need to make sure they are who they say they are. But the Ryan-Haight Act is really a major obstacle in this. It completely changes how we can deliver care quickly to these individuals. And so during the emergency order, the Ryan-Haight Act is suspended, but at the end of the year, it will come back into effect. We would like to see this permanently removed. It just doesn't help with this population. It just creates barriers. There are other ways to evaluate whether or not diversion and other inappropriate prescribing is occurring, as Dr. Mario mentioned. Licensure. We had a patient who was in a Pittsburgh hospital emergency room who resided in West Virginia. If you're familiar with that area of the United States, that's not too uncommon, and the patient was being referred to us. The problem was the patient resides in West Virginia, has a West Virginia Medicaid, but is in Pittsburgh. So now I need a Pittsburgh or a Pennsylvania licensed doctor who is enrolled and credentialed with West Virginia Medicaid so we can actually treat this patient. And then the patient's going to go back to West Virginia, so that provider also needs to be licensed in West Virginia. So these are some of the challenges that create issues with patients getting into care. We were actually called just because this patient was unable to see any of the local providers due to this issue. Physical location is another big one where we see physical location requirements within the state. For some reason, as a telehealth provider, walking into an empty office gives comfort and confidence that we are a legit organization. However, there's nothing in the office. We don't see patients in the office. So I think that these are some of the regulations that came about to stop fraudulent billing or fraudulent practices, whatever it might be. But in the telehealth world, you know, the healthcare plans like Molina are moving really quickly to adjust to this, and I understand that states and governments and other organizations take longer, but these are some of the challenges that you face as a telehealth provider, and these prevent barriers. If I have to pay for an office space that we're never going to use, then it creates problems because I'm not investing that back in patient care. Visit limits. Mario talked about having medication limits. Visit limits is another one we see in certain states where we're prescribing a medication that's highly controlled, yet they want to control that we only provide 6 to 12 medication or prescriptions per year for that individual. Well, if I have a patient who I'm suspecting of diversion, I want to limit the number or the length of that prescription. I don't want to hand them 30 days worth of medication. That's not good practice. And so we run into this challenge, and then we have to go through a long approval process. Well, the approval process sometimes can take 14, 21 days. I mean, it just makes it really hard to manage patients when we're fighting the systems as much as we're trying to manage our patients. And then Dr. Mario mentioned prescribing limits. So those are some of the direct issues that we encounter working as a Medicaid provider in 47 states. When we think about the situational issues, Dr. Mario touched on this one. Because we are a telehealth provider, pharmacy cooperation is really important, but because we're telehealth, they often are suspects of telehealth. And so if they refuse to fill the medication because they say, oh, well, I'm not familiar with this organization, I just looked it up on the internet and they're based in another state. Well, that's okay. As long as we are appropriately licensed, credentialed, and capable of delivering services, our providers are all licensed in the state, licensed to see patients in the state, we're following all the rules, but the pharmacy has the trump card on this. And so that runs into a challenge for us in terms of getting medications to individuals, and that's a really sensitive time, especially when we think about patients who, whether it's they're coming to us in withdrawal and we need to get them on the medication, or they've run out of medication and somehow are now back in withdrawal and we need to manage them. EMRs are presenting some of the challenges as well. They were never designed for working across states, so they always show one address. Our organization is located headquarters in California, so our EMR shows a California address, yet we're working in 47 states, so it's not uncommon for our ePrescribe. We use ePrescribe for everything. It's not uncommon for the address to show California. Well, a pharmacy in Ohio is going to say, what is this? Why is this California provider submitting a prescription to me from California? This doesn't make sense. This patient's in Ohio. Well, that's just an artifact of the EMR. We don't control that. We can't control that. It's the way the systems are built, and all of them are built this way. We could open up new EMRs per state, but again, we're getting into creating overhead that doesn't really end up delivering better care. And then sort of the last couple items all fall into the idea around service delivery versus outcomes, a lot of requirements by states and licensing around signing of treatment plans. Well, in the telehealth world, it's really hard to get a patient to sign a treatment plan if we want to use something like digital signature. It's just not really intuitive for individuals who are struggling with functioning. So we need to come up with ways to manage this in a way that fits the patient, but also provides confidence that the patient is engaged and agreeing to their treatment plan. Same thing around treatment plans being updated monthly. This gets into the digital health model. We're adjusting our care based on the individual and their interactions in real time. That may alter treatment plans. I may have a treatment plan to work on, let's say, reduction in substance use, but if I have a patient who's decompensating, I may need to quickly focus on distress tolerance. And so changing the treatment plan just to keep the patient retained doesn't necessarily align with how we want to create these treatment plan records that are updated on a monthly basis. They're updating actually much more frequently. We just ran into one where now we're being asked to pregnancy test women of childbearing age at every single appointment. That is overwhelming to the patient. They don't want to engage in care when they're being tested, and it becomes a barrier for them to want to stay in care. Another one was behavioral health versus physical health. Often we're getting patients who come in with chronic pain. That's a physical health issue, though we're treating it in many cases through the behavioral health side. And so you run into these problems of how we've set up the worlds of this is substance use, and there's a hard line. This is mental health, and there's a hard line. And then this is physical health. And we're crossing all that when we think about holistic care and treating the entire individual. So that's some of the experiences we've had, some of the challenges we've had, and what we're hoping for as we move post-pandemic. I don't like that word, but post-pandemic, we're hoping to see a lot of these be addressed. So, John, let me turn it back to you.
Thank you very much. It's very informative. And I know as a former Medicaid director in both D.C. and Ohio, many of the issues you raised that you say are barriers are things that, when we were implementing them, we thought, well, this is good. We're protecting people, right, in those areas. And it's how do we start thinking through some of those as we go forward. So I want to remind everyone, if you have questions, please feel free to put them in the chat box. We have had a couple come in, so we really appreciate that. I want to get to it. So before we get to some of your questions, we do have a few things or a few questions I have for you all. One of the things that definitely came up over the summer, talked about quite a bit, was health equity. And, how is it that states are able to address some of those issues? So given the disparities in SUD treatment, are you planning to have, or have you developed a health disparities and health equity strategy to try to mitigate the impact and treatment of SUD across racial and ethnic groups? And Dr. Mario, I'll kick it over to you first.
Sure. Thank you, John. Absolutely. Molina has put a high importance on population health, as well as the amalgamation with social determinants of health, and even issues around contracting, where all this kind of comes together. So you need to understand, number one, where those disparities are. So really, that's although there's data out there, we have a very unique patient population or member population that we are responsible for understanding and use and invest quite a bit in figuring out those that are most at risk for succumbing to the kind of things that in the world of SUD or other mental health that increase their utilization of services that are inappropriate, and increase morbidity and mortality. So understanding that is the very first step. National data is great, even state data is great, even census data is great. However, you need to know what your members, what's going on for them locally. And the reason that's so important is because one of our strategies in addressing this, and we're doing this through our Center for Innovation on Social Determinants of Health, is linking an appropriate and robust CBO, a community-based organization, type of an arrangement where there's a closed loop, that the data is actually collected, there's standardization from what it is that we're looking at, as well as from the provider side that we create opportunities to incentivize through value-based contracting those SDOH type of factors, and that's challenging right now. I mean, I think a lot of folks are running towards that finish line to try to get some things moving there. But that is part of our strategy, is creating the right incentive, understanding the groups, and then using our information systems to prioritize, in particular, around some of the things that we can control, because there's a lot that we can control from the standpoint of incentivizing and making certain things easier. And so when we see disparities around racial lines, ethnic lines, areas around language, and other cultural issues, then that needs to be of highest priority. So absolutely important for us.
Thank you. We got a question that came in from one of the people listening today, and that is, are there enough behavioral health and SUD providers to meet the demand that's out there? I think that's a question that comes up a lot for many of us policymakers. So the first question is, are there enough to meet the demand? And if not, how do we resolve that? So John, I'll kick that one over to you. What are your thoughts on that one?
Yeah, well, I mean, I think we know nationally that there aren't enough providers. But I also think that we exacerbate the problem because we don't leverage the providers that are available. Let's take Dr. Mario, for instance. He has all the qualifications. In fact, he's an expert in the field. He's based in California, yet he might have a free 2 hours. He could treat somebody in Ohio or Tennessee or North Carolina. But you run into a lot of regulation, licensure, credentialing that prevents that creates barriers for him seeing those individuals. And so I think utilization, and we talk about that a lot within our organization, is just how do we utilize providers across the nation. And one of the challenges that you have in getting a provider licensed is it can take 9 months. Yet right now in Delaware, they have a reciprocation that allows us to get providers active and seeing patients within, say, 30 days. And so those are the types of, I think, innovations that we want to see to help address this. From a training and who can treat these patients, I'm not qualified. Dr. Mario, you're probably more qualified to talk about like what you see in that area. So I'll turn it over to you.
Sure, and it's a great question. In fact, the American Society of Addiction Medicine is currently revising some policies around this, kind of the area of how do you identify somebody that is qualified to provide addiction medicine services. It's actually an important question because how we credential people in managed care organizations or in any sort of a structured health system makes a difference to be able to get the member, the patient, to the resource that they need. So, for example, in the case of medication-assisted treatment, just because you're X-waivered doesn't mean that you're an addiction specialist. So if you send somebody that also has a benzodiazepine use disorder or other things that are co-occurring, that might not be the best place for them. The other thing is that understanding network adequacy and understanding who's really available to provide care. Right now we have this system where we require an X waiver, for example, for an XDEA, special to be able to prescribe buprenorphine. Most of the people that are X-waivered, number one, are not addiction specialists, but number two, they are not operating at even at the lower levels of ability to be able to prescribe. So they might have one or two patients. Also, depending on their specialty, it could kind of shape the kind of patients they see. So, when I was more involved in direct patient care, I was one of the only providers, for example, in a certain part of Southern California that would see pregnant women that had opioid use disorders. And so to find somebody that was X-waivered, if you just look it up on the website to see that's not difficult. However, to find somebody who would also see somebody that's pregnant, or let's keep going on the list of special populations, an adolescent, right? We kind of look at that as between, say, 16 and 21, or in some groups 16 to 25. The reentry population, who's prepared to see those? And so what sort of qualifications they might have. All that comes into play when you're talking about what's adequate for that. So one of the main things that we can do for that has already been explained, and that's to really leverage the resources that we have, but also to understand better how we understand the resource that we have of the providers to see what's real from the standpoint of their ability to take care of people, not just in MAT, but also in addiction medicine services as a general thing, as well as mental health. Because they're not all the same, and it's a bit confusing right now. But that's being addressed in part by the American Society of Addiction Medicine. I think that managed care organizations and other health systems in general will adopt them so that there's some sort of standardization across the board, making it easier for credentialing.
Thanks for that. Keeping on this idea of are there enough providers, when we were doing changes to our system in Ohio, the Medicaid system, one of the issues that came up quite a bit was peer supports. And should we cover peer supports or not, and who could do those, provide those services? And there was quite a bit of engagement from the advocacy community here in Ohio to include those services. I know that we've gone beyond just peer supports into other areas. So, my question to you, and Dr. Mario, let's start with you, is how are you using non-medical support services as a way to better engage SUD members? Meaning, from the standpoint of Molina, what is it that you're working with providers in allowing for those non-medical supports?
Sure, and we fully support the utilization of folks that have lived experience or actually even other definitions around that. We don't want to pigeonhole the idea of what a peer support would be. Sometimes there could be even other terms that can be used, but from the standpoint of the engagement with the person that is afflicted with a substance use disorder, that it's important. We even go so far as to integrate peer support into our case management model. So we have an SUD navigation system at Molina where every state has folks that are trained, they're case managers, but they have we identify the champion at the plan. They're trained in advanced training in pain management, mental health, and substance use disorders to be able to serve as a subject matter expert in case management and to take the most complex patients around that, members around that, to be able to improve the outcomes for that group. And in that model, we have peer support, as part of the team and as part of the expertise that the health plan is to use in doing the care management. And we do have some experience and some pilots where it's been something that we certainly support. As part of some pilots, we'll continue to expand that through the Center for Innovation for Social Determinants of Health, and with an expansion of the definition of what we consider to be peer support, not just in SUD, but as it relates to mental health, and as it might relate to other areas where it may involve elderly and falls, for example, and other definitions around that.
Thank you. One of the questions we got from a person on the webinar, and John, I'll turn to you on this one because it's really directed towards you. How does Bright Heart Health work with Medicaid MCOs, care managers, or peer supports, or other people that they're using in care management to improve access and help members navigate the barriers that you were describing in your presentation?
Yeah, it's a great question, and it highlights the challenge that we have with this population, where when we look to work with health plans, we want to make sure that they're able to get their members into care very easily. And oftentimes, case management is going to be engaging a member. They might be discharging from an emergency department or a psych hospital or something like that. And what they want to be able to do is make sure that that patient is transitioned and is effectively in that other setting's care, so there is no real transition. It's a smooth transition. And so that's where I think having the virtual clinic and being able to work directly with case managers is really important. We talk about three-way calls with case managers, the patient, and Bright Heart. We support hospitals by putting telehealth kiosks in the hospital or in the emergency department so patients can actually see our staff, engage with our staff to get into care before they actually walk out the door. Discharge planning at its best, right? I know this patient is engaged in their care. They have the appointment. They're already set up to be in their care. So really thinking through when you have a virtual on-demand service, you can rethink really all the access points and utilize it wherever you are and wherever the patient is. And I think this is really important around serving at-risk populations, high acute patients where they struggle with staying in care. We work with a needle exchange program in San Francisco where we can't even offer the patients appointments because they just can't function at that level. So we run a walk-in service for them. That's how we manage them. They have to walk in. And that really helps out with the case management team because trying to fit people into boxes sometimes doesn't work. And we can start to address that. And I think Dr. Mario hit on the case. The peer support really plays a critical role in that. When we think about this population, it's really an integrative approach. And you have to integrate the PCP and other healthcare providers as well, because it takes everybody to work with this population to make sure the needs are met and to keep patients in care.
I think one of the things that comes up, and I touched on this earlier, is the concern from states of, are people getting the treatment they need? Is there diversion going on? And I know states, when they're designing their programs on the Medicaid side, are looking at some of those and saying, okay, people have to get certain services. So an example of that would be in some states, a person is required to get counseling along with the medication-assisted treatment. And if the person doesn't get counseling and the state is doing a claims review, they can go to the provider and start doing audits of the provider or use that information in a way that could be negatively impact the provider by either holding payment or not paying. That is a concern that's come up, I know, from states. You've touched on this a little bit of, in a telemedicine world, things are different. So what would your advice be to states in how to handle this issue of how to keep people engaged in getting medication-assisted treatment, but at the same time allowing for flexibilities around that? And Dr. Mario, I'll start with you on this one.
Sure. Thanks, John. Well, this is absolutely an important area, and actually spend quite a bit of time in terms of educating folks around medication-assisted treatment and even just the basics of addiction. When some of the policies are created, sometimes they might not have the subject matter experts in the room to think some of these things through. And these kind of policies are not just at the state level, but they can happen in a utilization review policy. They can happen in a pharmacy utilization type of policy. And so people get denied access to services because of something like what you mentioned around counseling. Now, we understand addiction to be a chronic relapsing disease. We understand a lot more about addiction than we did before, and a lot of information has come around in the last 10 or 15 years that have been well studied, and in this in particular has been resolved. We see the biggest changes. We see the statistically significant changes when people have access to medication-assisted treatment for opioid use disorder. The difference between dying and not dying, the difference between having overdoses, non-fatal overdoses, or not, the difference between even things like positive urine screens, if you're doing a study and evaluating folks, compared to when they don't have access to the medication with or without counseling. So the idea that you have to have counseling for it, or we will prohibit your access to the rest of good evidence-based care is not a good decision. And maybe this in the past was something that we didn't understand because we come from a model of abstinence only. Historically, I'm talking about in the culture of this country, the best that we knew of was really around abstinence only. In fact, we continue to struggle. There are treatment centers that won't admit somebody for detox, let's say, from alcohol if they're on buprenorphine for opioid use disorder. They may have been stable for a year, doing very well on that medication, but they might require them to detox, and I say that in air quotes, to withdraw from that as well, because they had this idea of, say, abstinence only. But it's very clear. You do not have to have counseling. Do we encourage it? 100% of the time. 100% of the time. But the idea that you would, if the patient is not there at this moment in time in their willingness to change, in the kind of their cycle of where they're at, that you would not then give them a life-saving access to medications is no longer something we embrace from the standpoint of standards of care, and I can tell you that across the board. So I would hope that states embrace the idea of engagement. How do we engage somebody that is at a point where, they can get exposed to even one overdose and bump into fentanyl and something they didn't even know had fentanyl in it and die, and then work our way into possibly adding more layers of services like counseling, like some education on naloxone and overdose prevention, like trauma-informed care, like addressing some of the comorbid conditions like hepatitis C or issues around psychiatric conditions. All of those are layers we improve the quality of life. Because why we're doing this, that we have to always acknowledge, it is not to control a chemical. It is not to control whether somebody uses or doesn't use. We're not trying to be police officers here. We're trying to improve quality of life. And at the end of the day, when you're in front of a patient and their family, that could be just, you know, are you in a state to love and be loved? Are you stable on the medication? That could be how simple this percolates down into. So I'm always more in favor of having access to that than not, and it's borne out in the data.
John, being a provider, thoughts on this question?
Yeah, Dr. Mario and I are very much aligned, but at a telehealth level, I'll look at it from that perspective. I think this is one of the challenges that you see in an advantage or an opportunity that you get in telehealth compared to in-person. So when somebody walks into an in-person addiction care program, they get put in front of the provider who does a medical assessment, prescribes the buprenorphine, and then they're set up in their, twice a month counseling session, and maybe they have group counseling, whatever. And the curriculum usually involves relapse prevention and recovery skills. But there are a lot of factors that you could look at that would tell us whether or not a patient is resistant to that, whether or not a patient needs that. How long until, as Dr. Mario just mentioned, how long until a patient is open to that? So when we look at it, we have a number of predictive factors that tell us what this patient is like when they come in. And we're not going to jam therapy down their throat when we know that that's going to lead to abandonment of treatment. What we're going to do is work with them to keep reminding them that we're available and we can help them out in a number of areas of their life where they're struggling with functioning. But we also realize that if we just do that for a couple of weeks, they'll come around to it once they start to stabilize. The patients are coming in complete disarray, unstable living structure, unstable functioning, And sometimes it takes, 4 weeks, 2 months to stabilize that patient to where they're finally like, yeah, you know what, I want to change this in my life. And so then we can start to have that conversation. So digital health really creates this idea of individual treatment approaches to each patient. It's not just changing a curriculum. We're actually looking at every patient across hundreds, if not thousands of variables to determine what exactly at this particular moment does this patient need to do the best. And so I think that's really the big opportunity.
Thank you for that. So, Dr. Mario, I'm going to finish up with you with the last question. We've talked quite a bit today about the great partnership Molina has with Bright Heart Health in delivering SUD services to individuals who need it. I mean, whether it's during the pandemic or after the pandemic, this is a tough area to get services to people. And I know states are always looking for how can you better serve the individuals and have good outcomes. And I think John has shown us some really great outcomes. Dr. Mario, you talked about some outcomes that were excellent that you've seen in the work that you all have done. So with that, what advice would you have for states and providers who are interested in forming this type of a SUD treatment partnership that you all have with Bright Heart Health, but don't know where to get started?
Sure. I'd say that really the first thing is to approach it in as holistic of an approach as possible. So tools like telehealth and then folks like Bright Heart Health, for example, they're one part of they're kind of one of the legs of the stool, and managed care organizations and other systems of care are another one, and then of course the member being the other, and so we really have to think of what sort of population are you aiming this towards, and what makes the most sense, because you can't boil the ocean, and telehealth is not the solution for everything either. So I would say that when thinking about any sort of a project, that you really delineate the group that you're thinking about, that you're wanting to affect, and making sure that the kinds of services that you wrap around it include things like the SDOH considerations, not just medications, that you also consider into that the kind of services that health systems can provide, particularly to a provider. So like a provider that might have difficulty in accessing services from a case manager because they don't have that in their office. What can, say, managed care organizations or others provide to fill those gaps? So when you're visualizing what sort of a thing that you're going to be putting together, it should not just be one little service. It really should be more a holistic approach, whole health approach to addressing both the physical, psychological, as well as the social needs for the member.
Well, Dr. Mario and John, thank you very much for your time today, and also thank you everyone who joined us today for this webinar and submitted questions. We really appreciate it. So for anyone who is interested in more of what we're going to be learning about, you can take a look at the last slide there. We've got a link to the website where we're going to be talking about this and future webinars. So we look forward to working with all of you in the future, and some interesting webinars that will be coming up. Thank you, everyone, for joining us today.